All right, so I've got some new markers, so hopefully I won't be throwing them around too much, as long as these guys work a little better. I think I'm really the only one that uses them real consistently, so I think it's all me. It's all my fault. They're dry anyway, so. All right, so let's move on. So we talked we did an overview of some of the major pharmacological interventions, pharmacological things that we have available to us. What I want to do is I just want to go back and redux some of the disorders that we run into, and make sure. Oh, before that, somebody Mike, was it you that had some questions about some terminology yesterday?
I got it taken care of yesterday.
Okay, yeah, about hypercapnia, hypercarbia. Those just mean too much CO2, buildup of CO2. Just other words that. Any other questions? I guess before. Yeah, go ahead. What's up?
In regards to what we talked about right now, let's say if a patient who has cardiac problems, and let's say her heart rate is maybe 140, close to 150.
Okay.
And she's having maybe asthma or COPD symptoms. Can you just give ipratropium instead of albuterol?
Well, yeah, ipratropium is not gonna rescue. So if you have somebody who's you're listening to them, they have significant wheezing, they have increased work of breathing, all the indications are there for albuterol. Albuterol is going to be the better, or Zopanex. A rescue agent is going to be the better way to go. But you're absolutely right. You really need to be cautious because what if you have somebody that has some cardiovascular history, or they have some history of tachydysrhythmias or something like that. Yeah, you've got to be cautious. But ultimately, you may have to give a rescue agent. In fact, that's one of the reasons that Zopanex came about, was that that particular isomer of albuterol they thought might have less cardiac effects, but we see that people that get Zopanex have some cardiac effects, just like people that get albuterol. So yeah, it's kind of a, you may have to give it. You're just going to have to monitor very closely. That's a good question, though. Yeah.
An epi inhaler. I know it's not in our protocols, but would that cause the same problems as albuterol?
Yeah, there are epinephrine inhalers, which you don't really see that a whole lot, but yeah, epinephrine inhalers would cause actually be more significant side effects than albuterol or Zopanex, because albuterol and Zopanex their effects are more beta-2 specific. There is crossover, beta-1, alpha-1 crossover, but not as much. Epinephrine, of course, would have more significant crossover. And there is the racemic epinephrine. What do we use that for? Just to make sure. I don't think we discussed that too much. You guys heard of that? Racemic epinephrine? Mentioned it, yeah. Racemic epinephrine is generally used for upper airway issues. So people that have upper airway inflammation or edema, croup, for example, croup kids occasionally get racemic epinephrine, and people that have been extubated, that get some a little bit of stridor, get some stridor after extubation, racemic epinephrine may be indicated for those people as well. Of course, racemic epinephrine is going to have more pronounced cardiovascular side effects, so that's something to look out for. But of course, stridor is always an indication of an upper airway issue. And actually, I need to grab the lung sound simulator this week too, and bring that down, and we'll do a lung sound lab with you guys as well. So, thank you for reminding me. I got to go to the other campus and pick up the sound generator from the respiratory program. Okay, so what I want to do now is I want to talk about some of the disorders, and I want us to spend a little bit of time talking about some of the disorders that might be a little more difficult to understand. And so I think the first one I want to talk about is ARDS. What is ARDS?
Acute respiratory.
Yeah, acute, or some people call it adult respiratory distress syndrome. That's very well. Okay, ARDS. What is ARDS though? What is the basic pathophysiology of ARDS?
It's an injury or inflammatory
toxic gas smoke inhalation,
Yeah.
viral infections.
There's some sort of insult. Oh, look at that. That's nice. All right. There's some sort of insult. I wish we had chalkboards, honestly. The old school chalkboards. I'd give it that. Yeah. The insult. There's some sort of insult to the lung. It could be toxicological. It could be inflammatory. It could even be related to perfusion. Some sort of state where you have decreased perfusion of the lung, like a shock state. People that go into a shock are in shock for extended periods of time. There's some sort of an insult that happens to the lungs, and then what happens after that insult? What ensues? Okay, you do have some inflammation, inflammatory changes. What else?
Aspiration.
Not aspiration. Aspiration might cause ARDS.
Infection.
Infection might cause ARDS. Let's say that this is an alveolus, and I have the membrane here, the alveolar capillary membrane. Alright. So I've got blood flowing through here. Okay, I've got gas diffusion occurring here. What's happening here in the alveoli?
Gas exchange.
So I do have some inflammation. What else do I have happening?
The surfactant isn't.
Okay, I have dysfunction of the type 1 and type 2 alveolar cells, right? I have dysfunction of those cells. Those cells aren't working, their integrity is compromised. Alright? And the alveolar capillary membrane is compromised. And when that membrane is compromised, the permeability of the membrane increases. And what does that cause? The permeability increases, then what happens? Inflammation, I've got increased permeability, I have destruction, damage of the cells. What happens?
Pressure moves in.
Okay, what kind of pressure becomes relevant? So here I have a blood vessel. Okay, cross section of blood vessel. I have two types of pressure that I worry about, right? What are they?
Partial pressure.
No, blood vessel. Blood vessel. I've got fluid flowing through a vessel. Okay, there's a kind of pressure that wants to push fluid out of the vessel, right? And then there is pressure that wants to pull the fluid in. Okay, so you have proteins and dissolved particles inside of the blood that creates osmotic pressure, right? And that tends to pull the water, want to keep the fluid in the vessel, okay? And that's known as oncotic pressure, right? So oncotic pressure. And then there's a pressure of the blood, okay, pushing on the outside of the vessel wall, that the pressure of the blood, the fluid wanting to escape out this way. And what's that pressure known as? That is not osmotic. Osmotic is in here. Osmotic is part of what causes oncotic. That is known as the hydrostatic pressure. The hydrostatic pressure is going to push. Well, what happens if this vessel becomes leaky? I destroy some of the lining. What's going to happen if I do that?
As much pressure.
Well, the hydrostatic pressure is going to do what?
Push fluid out.
Fluid's going to get pushed out of this vessel. Right? Fluid is going to push out. And that's what happens in ARDS. You have destruction, inflammation of the alveolar capillary membrane, and then the hydrostatic pressure will start pushing fluid across that membrane into the alveoli, and then the alveoli begin filling up with fluid, and you develop pulmonary edema. Right? And that's one of the classic findings for ARDS, is this pulmonary edema. Now, this pulmonary edema of ARDS is very different from cardiogenic pulmonary edema. This is non-cardiogenic pulmonary edema, right? Okay. The mechanism of cardiogenic pulmonary edema is a little different, right? That's due to the heart failing. And as the heart fails, fluid kind of backs up in the pulmonary circulation. The left side of the heart is not accepting the fluid. So it backs up in the lungs, and the hydrostatic pressure increases, right? There's an increased hydrostatic pressure as it backs up, until fluid transitates, across the alveolar capillary membrane, is literally kind of pushed into the alveoli. Does that kind of make sense? The pulmonary edema that we see of ours is very different from that. Okay, this is actually due to the compromised alveolar capillary membrane. The membrane itself is being compromised, and you don't have this component of heart failure going on. So how are we going to treat somebody with adult or acute respiratory distress syndrome? What kinds of treatment modalities are these patients going to need? Okay, they're going to start off with Cpap. And the pathophysiology of ours is prolonged, okay? This is something that takes several days to really develop. Okay, you could have your insult, on Monday, and you might not develop ours until Tuesday, Wednesday, Thursday, later on in the week. Okay, this does take some time to kind of develop and to kind of mature, if you will. Does that kind of make sense? Alright. So you have this progressive respiratory distress that's developing, and you have hypoxemia and hypoxia occur, and this hypoxia occurs in spite of giving high FiO2. Okay, so you're increasing your oxygen, you're starting your patient on Cpap, they're getting worse, and eventually what do you think is going to happen? Yeah, they're going to have respiratory failure. You're going to have to intubate them, right? You're going to have to intubate them. And this is where we often see these patients. Definitely where you'll see them in clinicals. Okay, they're in the ICU, they're intubated, they develop ARDS. Or you're transporting them from one hospital to another and they develop ARDS. And the question is, how do you manage somebody with this kind of pathology going on? What kinds of things do we need to be doing to help manage them? What do you guys think? Manage their respiratory issues.
Get the fluid out.
Okay. Actually, diuretics are not going to work for ARDS. The diuretics are not going to be very effective because a diuretic doesn't. This is the problem right here, right? This is the problem right here. Diuretics is not going to take care of this problem here.
Anti-inflammatories?
You'd think, and steroids may have a role. What are things that you guys can do as providers, though? If you're managing this patient's intubated, you've got to manage them for a certain period of time. What kinds of things are you going to need to be doing?
Ventilating oxygen.
Right. How though? What kind of breaths do you think you want to be giving them? You want to use a lot of. Do you want to use a lot of force? You want to use a lot of volume? Really high pressures? Is that the kind of stuff you're looking at? What do you think?
Push the fluids out.
Okay, so you actually don't want to be giving these patients really large breaths. You don't want to be using a lot of pressure on these patients because that pressure can damage their lungs more. You want to use what's known, and I think Cheryl mentioned this yesterday, something known as lung protective strategies. Was that something she mentioned with ARDS? A lung protective strategy? No? No. Okay.
She did tell us whatever you instructed her to tell us, though.
Okay.
That's a true story.
I was instructed to tell you
What? Something
In her defense,
about what?
whatever you told her to tell us, she told us.
she just dropped so much knowledge on us.
Oh, okay. Cool. Lung protective strategies. So when we start talking, we haven't really talked about ventilators yet, but when we start talking about ventilators and setting them up, this will be really important. We want to use smaller than normal volumes. We do not want to overinflate, overexpand these lungs. Okay, we want to minimize the pressures. Now, we will still want to provide some positive pressure, though, to prevent the alveoli from collapsing. So things like PEEP or Cpap will be important to prevent the alveoli from collapsing, but we don't want to overdo it. We don't want to be giving our patients too large of volumes as well. So we want to use lung protective strategies. And we'll talk about those in a little more detail. But that's a big thing when it comes to ours, is a lung protective strategy to help those patients. Okay. So moving a little away from ARDS, and of course ARDS is associated with irreversible shock. In fact, the first name for ARDS was shock lung. That was actually one of the first names given to ARDS, because from the Great World Wars, we saw, or surgeons saw, patients that had bled out, lost a lot of blood, were hypovolemic. They ended up developing this pulmonary edema several days after their injury. And so they coined the term shock lung, which is now, of course, called ARDS in those circles. Okay, so now what I want to do is I want to compare and contrast some of the disorders that Cheryl had talked about a little bit yesterday. So we have two major types of disorders. We have obstructive. I have obstructive respiratory disorders, and I have restrictive. All right, I have restrictive disorders, obstructive and restrictive. The ones that we run into quite a bit are the obstructive pathology. So let's just talk about obstructive. What do I mean when I say obstructive? When I say, yeah, it's an airflow. There you go. It's an airflow problem. It is an airflow problem. It's an airflow problem. And the question is it air getting in or air getting out primarily? With obstructive pathology. It's air getting out, right? That tends to be the hardest part. Why is it harder to get air out in obstructive? If I have airway obstruction, I have bronchospasm, I have mucus plugs and things like that, inflammation. Huh? Yeah, why exhalation? Why is it that exhalation the big issue, not inhalation as much?
Pressure. The body relaxes when it exhales.
There you go. You got it, Lon. It's exhalation is a passive process, right? It's not an active process like inhalation. Inhalation, you're actively using a lot of muscles. So what happens is, if I have obstructive pathology, I have bronchospasm, I have inflammation in my airways, I have mucus, increased mucus production, all those things occurring, I can inhale reasonably well because I'm actively using a lot of muscles, but then when it comes to exhaling, generally exhalation is an active relaxation process, and now when I'm exhaling, I'm having to use a lot of work. These patients are having to work very hard to exhale to actually get that air out because the body's used to that being more of a passive process. So it's getting air out, and it's air getting trapped. That's a big problem as well. Air trapping. Air gets trapped in there, and you can't exhale it out, and then it just kind of gets trapped, and you get something known as auto-PEEP. You have all this air trapped, your lungs are overexpanded, and that causes problems with, of course, with worker breathing, puts pressure on the heart, the vena cava, and your cardiac output's compromised, and it can become a real big deal. So, what are some common types of obstructive pathology that we run into out in the field?
Asthma.
Okay, asthma. Asthma is a huge obstructive disorder. What else? What's the other disorder? It's a group of disorders. COPD. Yeah, COPD. Now, some people say that asthma is a form of COPD. Okay. There's a lot of discussion about that. Asthma, one of the major things that you want to know about asthma, okay, asthma has what's known as reversibility. Okay, asthma has what's known as reversibility. If I develop emphysema, That's an irreversible disorder, right? That's irreversible destruction. It's irreversible pathology. Now, there are things I can do to prevent or to slow the progression of the emphysema down a little bit, right? I can prevent it from getting worse, I can slow it down, I can rehab, I can optimize, but I am never going to make somebody with emphysema not have emphysema, right? I can never take it away. But asthma, a lot of patients have reversibility. We can get them on the right meds, we can get them on a good plan, and we can reverse a lot of the changes in asthma. So a lot of people say that asthma is separate from COPD because asthma has this reversibility, whereas your COPD patients are not. These are generally chronic, progressive problems that tend to kind of get worse over time. But the underlying pathology between asthma and COPD is very similar. It's obstructive, right? It's obstructive in nature. It's an airflow obstruction problem. So when I think of COPD, the traditional way is think of CBABE. All right, CBABE. These are the 5 traditional forms of COPD. You have CF, which is known as cystic fibrosis. Okay. Bronchiectasis. Asthma. Chronic bronchitis, and then E is emphysema. So these are all traditional forms of COPD, and of course we talked about asthma and how a lot of people don't really look at asthma because of that reversibility. So let's just talk about these in just a little more detail. Tell me about cystic fibrosis. What is CF? What is cystic fibrosis? Yes, it's a CF. Is this something that is this a chronic condition that you catch after years and years of smoking or exposure to smoke? Or is it that kind of disorder, or is there something special about cystic fibrosis? It's genetic. Yeah, it is a genetic disorder. Yes. I believe it's autosomal recessive. It's a genetic disorder. You're born with CF. So it's very different than the other forms of COPD. You're born with it. You have large amounts of secretions. That's the big thing with CF. Large amounts of secretions. And these secretions become very thick. Okay. They're very viscous, they're very sticky, they hold on, and they're really difficult to get out of the airways. The life expectancy for CF is not particularly high. Okay, we do have people now that are pretty consistently living into their 40s, but typically end up dying of pneumonias and things like that. Got all this mucus in there. You're high risk for pneumonia. And has anyone ever seen somebody with cystic fibrosis? Yeah, it's basically just a life-altering disorder. These patients are always taking nebs. They have to inhale what are called mucolytic medications. These are medications that break up mucus, things like Pulmonary. They have to do vibration therapy, or what's known as percussive, CPT, chest percussive or chest physiotherapy. A lot of times they'll have like vests. They'll actually wear a vest and they'll turn it on, and the vest will actually vibrate their entire chest wall, trying to break up that mucus. In the hospital, we have what are called little pneumatic thumpers. You hook it into the wall oxygen, and then it's a little handheld thing. And if you get it during clinicals, if I do any of your clinicals, I'll definitely be looking out for things like that, so you can actually do CPT on your patients. And then it has like a little thumper that you can set how fast and how hard it hits a patient, and it just vibrates their chest wall, and you hit all the different lobes of their lungs, and you hit those areas and you break up that mucus. They're always on antibiotics, so it's a really life-altering illness. Bronchiectasis is a chronic a condition, it shares some similarities to CF. Bronchiectasis, you get a lot of inflammation and a lot of mucus secretion of the bronchioles. Okay. Of course, we talked about asthma. What's the difference between chronic bronchitis and emphysema? What's chronic bronchitis? Yeah, so chronic bronchitis is more a disease of the bronchi, the bronchioles to some extent. Okay, so you have inflammation, mucus production, whereas emphysema is an actual destruction of the alveoli themselves, that you actually have destroyed alveoli. We looked at those microscope slides of emphysema in lab. And you have destruction of the alveoli, you lose all that surface area, you have these large open air pockets and you get air trapping and all that stuff. That's emphysema there. Do we typically see people that just have emphysema, or just have chronic bronchitis, or just have bronchiectasis? Is that typically what we see? No. What we typically see out in the field with real people is that they have a combination. Okay? They have a combination of emphysema and chronic bronchitis. Some people may have more emphysema than bronchitis, or more bronchitis than emphysema. And you may have heard the term blue bloaters and pink puffers. Have you ever heard of that term? Okay, what does the term blue bloater refer to? And this is not something you put in your chart, by the way. This is okay. This is an informal term that we use. What does that refer to? What kind of patient? Yeah, blue bloaters are commonly used to refer to your chronic bronchitis patients. Okay. They're chronically a little cyanotic, can be a little heavier, okay? And then what about the pink puffers? Emphysema, yeah. And the pink puffers tend to be, they say they're pinker looking, they tend to be very cachectic or skinny. They have a big old barrel chest, they're thin. They're in the tripod, they're always breathing really hard, they're using all their energy to work on breathing. Because remember, they have all this air trap, they have all these large pockets and collections of air, and so they're working very hard to get that air out. Now in real life, this is not really what we see. We see patients that have a combination thereof, and they may be a little more bronchitis, a little more emphysema. But it's very common to see combinations of these things. Now, our treatments are generally going to be very similar, though. Okay, if you suspect that you have bronchospasm, you're gonna rescue them, right? Bronchodilators. You're going to give them fluids if they appear to be dehydrated. People in respiratory distress are at high risk for dehydration, right? Like asthma patients, and you want to give them some fluids, right? If it looks like they need fluids, give them fluids, right? That can help help with their secretions. Increase their volume status. So don't be afraid to give them a little fluid. It looks like they need it. CPAP may be effective, may not, right? CPAP may be harmful if there's significant air trapping, or it may be very helpful. CPAP is an interesting thing. It used to be that people would never give CPAP to asthma patients. They don't know, it could hurt them, and now we're finding out why. It may help some people with asthma. And we'll actually be doing some CPAP setup in lab. I know most of you are pretty familiar with setting CPAP up. As a general rule, CPAP, if it's going to work, it's going to work pretty quick, right? Within the first 15 minutes. And if it doesn't work, it doesn't work. And you just have to continue assessing your patient. You might have to DC that. We'll also talk about the Venturi mask in lab, delivering high flow therapy, and what that actually means. We talk about flow. Okay, so you guys okay on your obstructive pathology? That makes sense? Now let's talk about restrictive pathology. How do you think a restrictive pathology might contrast to obstructive pathology? Okay, so it's not an airflow problem. Air can get in and out of the lungs, but what kind of problem is it? It's diffusion, diffusion like emphysema is a diffusion problem. So when I say restriction, what does that think of? When I say the word restriction, restricted, what does that make you think of? You're not allowed, right? I'm inhibiting, I'm preventing, right? If I'm restricting your movement, I'm holding on to you and restricting, I'm preventing you from moving. So what do you think that might refer to as far as the lungs go?
That's right.
Yeah, you're on the right direction. You're on the right track. This is actually preventing the lungs from expanding and collapsing appropriately. It's actually a lung problem. It is the restriction of the lungs. The lungs can't open up. Okay, you're restricting the movement of the lungs. Okay. It is what's also known as a compliance problem. It is a disorder of low compliance. Your lungs are stiff. Think of it that way. Okay, they're stiff, they're non-compliant, they're low compliant. They don't want to move. Does that kind of make sense? So let's talk about the disorders that can cause restrictive pathology. Okay? So, pulmonary fibrosis is a group of disorders that can cause that, where the lung tissue, healthy lung tissue, is replaced by fibrotic scar tissue, and that scar tissue is very restrictive. Okay, it's very stiff. So if your patient has a history of pulmonary fibrosis, okay, they have a restrictive disorder. They have low compliance, not necessarily an airflow problem. Okay. What else do you think might prevent the lungs from expanding? What other things could fall into it?
Pneumothorax.
Okay, pneumothorax. Okay, I'll buy that. Pneumo. What else?
Hemothorax.
Okay, fair enough. Okay, yeah. All right, yeah. All right, yeah. Okay, cool.
Muscular dystrophy.
That is actually a neurological disorder. And that, which we'll actually be talking about. But yeah, that's more of a neurological. It's not the lung tissue itself. If you had nervous connection to lungs, it would probably work. But I like the way you're thinking, definitely. Perfect.
Puncture.
Trauma. Yeah, trauma's a big one. Chest wall trauma. Okay, if I have crushing injury to the chest, I have a large flail chest. Are those lungs going to be able to expand if I have my chest wall? What if I have my chest wall burned circumferentially? I have second or third degree circumferential burns around my chest wall. Do you think that's going to restrict the movement of the lungs? Absolutely. I'm going to have that eschar develop, right? And the lung wall won't contract. Another one, being pregnant. Pregnancy is restrictive lung disease. Okay, because the more gravid you become, okay, the larger your uterus becomes, and the more it pushes up onto the diaphragm, and the less that woman can expand her lungs and her chest wall. So that kind of makes sense. Okay. Incidentally, pregnant patients have much higher incidences of failed airways because you have fluids redistributing, and you have swelling, and you have distortion of the anatomy. We find that it's much more difficult to intubate people who are pregnant than people who are not pregnant. So if you're dealing with a critically ill or injured pregnant patient, that's something you want to have in the back of your mind, that this patient might be a much more difficult airway than you would anticipate. But generally, pregnant patients are really good to get IVs on, right? Have you ever had to do IV on somebody in their second or third trimester? Pretty darn easy, isn't it? You know, they're full of fluid, veins are popping up, they look pretty good. So a pretty good candidate for putting an IV into. Okay. ARDS. You think ARDS would be a restrictive disorder? Right, we have inflammation, destruction of the alveolar capillary membrane. Yeah, ARDS. ARDS and pulmonary edema in general, you know, can do that. What about pneumonia? Could pneumonia be? Yeah. And another one, it's a more trauma-related, but something known as abdominal compartment syndrome. I won't even throw it up here, where you can actually, the pressure inside your abdominal compartment can increase. It can put pressure on the lungs as well. In fact, in a lot of trauma centers now, what we'll actually do is we'll put a Foley catheter into the patient, and the Foley catheter goes in the urine, into the bladder, actually has a pressure manometer built into it. And we can measure the pressure inside of their abdominal compartment based on that Foley catheter that's put in. And it happens a lot, especially if you do like a high volume resuscitation, where your patient goes into the resuscitation bay, they get lots of fluids, they get lots of blood, and they have some sort of trauma. You can actually have a lot of that fluid leak out into the abdomen, and you get some inflammation in the abdomen swells. And there are several others that could fit into the restrictive category. But here's the question: if it's a restrictive disorder, do you think treating it like an obstructive disorder is going to be very helpful? What do you think? Yeah. So if somebody has chest wall trauma or they have a pneumothorax, giving them albuterol probably not going to be all that effective. Okay. So you got to be mindful that there are very different treatments for these, and some of these are not going to be able to do much. Like if somebody has advanced pulmonary fibrosis, is there much you can do about that? There's not really much you can do about that other than support them. And know that they have a restrictive disorder, and know that if you have to bag them, or you have to intubate them, or do any sort of airway management, you need to be very careful about how you ventilate them, okay, because of that lung compliance. And you want to be careful here as well, particularly like with emphysema and asthma, where you get a lot of air trapping. You want to allow your patients plenty of time to exhale when you're obstructive, right? You want more time for exhalation here. Generally, if you're restrictive disorders, people can exhale just fine. Those lungs don't have any problems emptying. It's getting air into the dark lungs that's a problem. So this is kind of an any problem here. This is kind of a getting air in problem, and this is a kind of getting air out problem. And then it gets really complicated if you have somebody with COPD that just happens to get a really bad pneumonia and then they develop ARDS on top of that. Then you have a getting air in and a getting air out problem, and it just becomes a very, very complicated patient. And we know that COPD patients are at very high risk for pneumonia. And you guys, I think you guys talked a little bit about pneumonia yesterday? A little bit? Okay. What's one thing that can differentiate pneumonia? If you think someone may have pneumonia, how can you differentiate that possibly from other diseases or other types of pathology? Fever, presence of fever is a big thing. In some patients who get very sick or they get what we call septic, they may actually have a low temperature. They may actually be hypothermic instead of hyperthermic. So that's kind of an odd way of presenting, but it is. Yes, sir.
How do we treat that new virus D68 that's spreading around for kids?
They are treating it with supportive care.
So like, are we going to transport pretty much, or?
Yeah, transport and supportive care. Unfortunately, there's just not much they can do. Different fluids. Okay, these kids, if they've been sick for extended period of time, they're probably going to be volume depleted. Okay, they might be febrile. So definitely giving them a good, fluid, 20 milliliter per kilogram fluid bolus, be a helpful thing. Monitor their temperature. If you do your pulmonary assessment, and actually Ed is going to be coming on Thursday and talking about advanced pulmonary assessment, so he's going to be laying down some of those physician assistant skills that he's picked up on you guys. I'm excited actually. that you'll be able to bring some of that in here as well. But if you take a listen to your little carpet commando and that little guy or gal has what sounds like wheezing or something like that, you might consider giving them albuterol. But it's still a lot of supportive care, unfortunately. That's a great question though, because that who knows what's going to happen with that?
It's probably
With that-
from here, that's why.
Yeah, with that enterovirus. Because basically it's like a cold virus on steroids. Is kind of, it belongs to that general superfamily of viruses. It's a really bad cold virus. But okay.
She's gonna be sick. You don't have it.
I'll just have it on top
It
of
won't
my,
make a difference,
my
is it?
monitor.
Yeah, you're an adult, so you just got a cold. You never know. You just got a cold. Just don't sneeze on me.
You have a cold, don't put a mask.
That's right, put a mask on. Go to the back.
Just get up.
Get out of here. But no one here is a germaphobe though, right? You would be healthcare. Probably most what? There are germaphobes here? Okay, but see, probably most of you guys aren't germaphobes, right? Most of you guys are like, egg falls on the floor and you're like, whatever, 9 seconds rolling. That's how I roll. It looks okay, I'm gonna eat it. So that's just EMS, right? Survival of the fittest there. Okay, so we talked a little bit about obstructive and restrictive disorders. I think we're sitting in a good spot here. It's about 11:15. Let's just get you guys on a little lunch break. I'll see you guys back at about 1 o'clock. Will that work? That give you guys enough time to get out and do what you need to do. We'll do lab. We're going to be doing some more intubations, but today we're going to talk about some techniques to help with difficult airways. So we'll be pulling out the bougies. I'm going to show you some techniques. Have you guys ever seen an intubating laryngeal mask airway or an ILMA? I'll show you how to intubate through an LMA. I have a video laryngoscope that it's called the Keen Vision. We'll be pulling that out. You guys will be getting to use that. And if we have the equipment here, I will start on nasal intubation as well with the BAM, the back airway airflow monitor, which is fun. And then by Thursday, probably by Thursday afternoon, you guys will be doing the Airway Olympics. So we'll have a little bit of a competition, right? I love competition. It brings out the best of people. So you can expect some really interesting things to happen there. And then next week, the labs will be more scenario-based, where you'll be coming in small teams. You'll actually have a patient with some sort of pathology going on, some sort of scenario, and you'll have to manage that patient to include IVs and meds and airway, and we'll be kind of pulling things together. Now that you've had the cardiology and you've had ACLS, you actually are able to do a few more things and actually run some scenarios. And that's what we're planning. All right, get out.
Wait, what time here?
1 o'clock? Yeah, it's like what 11:20 or so. So
I have
yeah.
a medication question.
Oh yeah. What you got? What you got?
Say you have a patient who's taking Tylenol.
Mhm.
If you're not supposed to give them, you can't give them albuterol because it's a.
You can give albuterol.
Because Paul had mentioned that albuterol would work.
It won't be as effective. Yeah.
So would there be like a different medication?
No. You definitely might want to give them anticholinergic as well, because the anticholinergics will still work like Atrazine. But yeah, if somebody is taking a non-cardioselective beta blocker, that's a great question too. Yeah, the albuterol Xopenex will not be as effective. Yeah, it's not going to harm them, but it won't be as effective. And you may have to give more. You may have to give an hour-long treatment. You have to be you may have to do it a little differently. Normally, we don't like to people that have any sort of reactive airway. We do not like to put them on non-cardioselective beta blockers for that reason. But that's a good question because some of you have test anxiety, and occasionally Oh, and occasionally people will get propranolol to get through tests. So if you happen to be taking a test and have an asthma attack because you're anxious, then I guess that would be good knowledge to have it.
Oh, that's not big enough.